Okay, I have the distinct pleasure of introducing our next speaker. She's in Paris, France right now, and she's going to, we're going to have a recording of her presentation, but she's going to join us live for the Q&A. So just a reminder, we'll have to come up to the microphone to ask questions so she can definitely hear us. So Dr. Robert is a professor at the Cummings School of Medicine at the University of Calgary. She is the medical director of the Calgary Chronic Pain Program and the medical lead of the Alberta Virtual Pain Program. Magali is the chair of the Urogynecology and Pelvic Floors Disorders Committee. Hard to read up here. Welcome, Magali. She's going to be talking about disentangling chronic pelvic pain. I know.
I'd like to thank the scientific committee for allowing me to talk about something I'm passionate about, treating pelvic pain. We have a very short time together, and so it's not going to be possible for me to discuss all aspects of pelvic pain. But what I'd like to talk about, and I hope you get a feeling for, is how all of chronic pain is intertwined with pelvic pain, to try and untangle some of the complexities of pelvic pain and just begin that process of disentangling, so that we're going to be able to, I hope in the future, build on these foundations.
Hi, Dr. Roberts, it's Dave. You can hear me there? Brilliant, that's great. I'll bring you back.
Chronic pain conditions. Did you say low back pain? Good guess. Maybe migraines, fibromyalgia. This is a talk about pelvic pain. And what I'd like to tell you is that 26% of women likely have chronic pelvic pain. This is also seen in men, but probably underreported. So we're talking that pelvic pain is the most common chronic pain condition. And yet we stay silent. So the first thing I needed to think about is going to a good source to try and understand. So off I went to Reader's Digest, and this came up. Women's pain is so often dismissed. Women are told it's all in their head, that they are not being heard. So then I went to my next source of information to try and understand, why are we as women so silent about pain? And yet we talk about the pelvic region quite openly in society. You've all heard of the vagina monologues, and you've probably never heard of the sequel because they probably wouldn't sell tickets. They don't talk about the elbow monologues or the nose monologues. And so there is something about us that even though we're silent, we openly talk about the pelvic region. So then I went to my next source, which is Cosmopolitan. And in this issue, one of the topics was the top 38 words that are used to describe or to use instead of vagina. Wow, 38. I don't know 38 terms for the shoulder or the knee. And as well as you can see on this cover, the truth about orgasms. So the pelvic region is something we talk about all the time. We remain silent about it. And so then you've got to wonder, what's going on? Well, I would say that we're getting a lot of conflicting messages, because even though we openly talk about it, we also use the word privates. And in fact, going to my next source, the thesaurus, there's 194 synonyms for privates. And maybe this dates back to Adam and Eve, where we openly can show the rest of our body, but when it comes to the pelvic region, we need to hide about it. So you can see how, on one aspect, we keep talking about it. On the other aspect, it is shrouded in silence. And in there is intertwined pelvic pain. So it's really important that if we're going to address pelvic pain, we need to take a gender lens approach to it. We need to recognize that pelvic pain is socially stigmatized. This is why women are silent. That we talk about private areas of the body and things that we don't openly talk about as an individual, even though as a society, we seem to be quite engrossed with it. And that the pelvic region is actually heavily laden with meaning. It is related to our identity as women, as men. It is related to parenting as it relates to childbirth and with sex and pleasure. And this is important when we start addressing pelvic pain. And so why are we silent? So the first thing we need to do is to recognize our own biases. That pelvic pain has been in the realm of gynecologists. And in fact, when I started treating pelvic pain 20 years ago, I was told that what I was doing was committing professional suicide. And people tried to talk me out of treating pelvic pain. And oftentimes now when we think of pelvic pain, we think of endometriosis, we think of dysmenorrhea, and we think of abuse. And we don't go much beyond that. And what I'm going to talk about is the fact that if we think of the pelvic region here, it's incredibly complicated, lots of things going on. We urinate, we defecate, women will menstruate, we have sex, and I'm going to use the word sex here, and also childbirth. So really that whole pelvic region is part of excretion and reproduction. And if you think about society, usually we do these in a private areas. We do them in bathrooms and closed stalls. Reproduction is usually in a closed room. It's not out in the open. And so again, things we openly talk about and yet still shrouded in this area of privacy. And so not only then have women been silent about it, but ourselves as healthcare providers have also been silent about it. And maybe the other thing to recognize is that pelvic pain is incredibly complex. Certainly, we can't dismiss the psychosocial. In the pelvic region, we have visceral organs. There is a hormonal component in women that will modulate pain. Musculoskeletal structures in the neighborhood, as well as neurological, both our sympathetic system as well as our somatic system. And so the next question I'm going to pose to you is, what is the most common chronic pelvic pain diagnosis? I'm going to say this after dysmotility disorder. So this would be irritable bowel, knowing that at least 50% of women are going to have multiple diagnoses. Is it cyclical pain? We've put this in the realm of gynecology. Musculoskeletal, vulvar. We have painful bladder syndromes, pudendal. And 80% of the people presenting with pelvic pain, it is not a gynecological diagnosis. Wow. And yet it is in the realm of gynecology. In this review through JAMA, kind of start to understand some of that complexity and some of these interactions that happen. We have visceral structures, we have somatic structures, and they intertwine together. And so 50 to 90% of women who are coming with pain have musculoskeletal pain. 48% have bladder pain, have endometriosis. And up to 75% who have bladder pain also have irritable bowel. And so what we're seeing is this sort of interaction of pain of people presenting with multiple nociceptive pain inputs. And 20 to 50% of women will come in with cyclical pain. So how can we look at this a little bit deeper? I'd like to think of nociceptive pain, or maybe really we should call it nociceptive sensory input, a little bit like the roots of a tree. And the roots of the tree are quite different. We have different root systems. So let's look at some of these systems and what they mean. we have the visceral system. So this is things like dysmenorrhea, endometriosis, painful bladder syndrome, irritable bowel syndrome, vulvar pain, just to name a few. And if we look here and we look at our parasympathetic innervation, we can see that all these structures in the pelvic region converge to the pelvic nerve and then go to the sacral area of our spinal column. So you can see how we would see this convergence happening of this sensory input. And as well, when we look at the sympathetic system and where the pelvic organs are, they also all converge along a whole chain. And how this will interplay in that vocabulary or this talking, this narrative that happens even in this root system at that level. And then we have the somatic sensitization. So these are the pelvic floor muscles is what we tend to call the whole grouping of them. The levator, A9, it's different structures. The coccygeus muscles are the ones we usually talk about, but we shouldn't forget the obturator and turnus that are here. They, even though they are hip muscles, are an important part of that pelvic region. And what I want you to recognize is how you have the urethra, the vagina, the rectum, these visceral organs actually going through the pelvic floor, the somatic system, and already you're seeing that relationship. But the pelvic floor doesn't work in isolation. We know that it is intimately tied with our diaphragm. They move together. So when the diaphragm contracts, the pelvic floor should relax. When the pelvic floor contracts, the diaphragm should relax. And so they're moving together. So we can't even isolate that somatic system in the pelvic region all alone. And it gets more complicated. Whoops, sorry about that. I got excited. Because the pelvic floor is also considered part of our core muscles. Now we could debate exactly what that means, but think about it more like this canister around the abdominal pelvic region and how we need to be breathing, we need to be evacuating, and how these muscles all interact together to allow all these to happen, as well as to keep us together especially when we're upright. And so the pelvic floor is a huge part of that, and we don't tend to talk about it. Why is that? Probably because it's hidden. We can't see it. And so then if we can't see it, we're not going to talk about it. It's private. In addition, I want you to appreciate the idea of anatomy train. So this is the musculofascial planes that move in the whole body. And notice in the pelvic region how everything seems to converge in this area. So it means that any type of movement is somehow linked to the pelvic region, and we cannot ignore it from there. So we need to be looking, when we look at pelvic pain, we need to see the broader picture of what's going on in the surroundings as well, in the whole body. Wow. And so now let's look at the next system, which is our hormonal system. And another part of our root system, where we're talking about cyclical pain. And the studies are a little bit conflicting, but essentially, when we look at experimental pain, these can be even in people who don't have any pain concerns. We know that different pain pressure thresholds are different throughout the menstrual cycle. So here down below, you have what the menstrual cycle looks like with the hormonal shifts that are going on. And what we find is, generally speaking, in the follicular, which is right after menstruation, in the ovulatory, the luteal, just before you are menstruating, and afterwards, just premenstrually, that we see usually an increase in pain thresholds, especially to pressure and to cold. And so because we've seen that hormonal fluctuation, a lot of people think that all of pelvic pain is endometriosis. But endometriosis, which is really the endometrium tissue that is outside of the endometrium into the pelvic cavity, and it usually will go to areas and change and fluctuate with the cycle and are hormonally sensitive. But the picture is actually complicated because 30% of women who have pelvic pain have endometriosis, but about the same number of women who have endometriosis have no pain. And so somewhere in there is that convergence of women with endometriosis who have pain. And there seems to be a lack of correlation between these lesions and pain. And we know that hormonal suppression is usually insufficient for pain relief. And we also know that surgery, where we look at excising endometriotic implants, usually will help for pain for 6 to 12 months. And then we see pain returning. And so there must be something else going on that hasn't been accounted for in most of these women presenting with endometriosis. And so we need to recognize that not all of pelvic pain is endometriosis. And there's something more about endometriosis. Potentially, we're causing neuroplastic changes and we're perpetuating that pain cycle. We've started that inflammatory cascade. Or is there another cause? In fact, we're looking at another part of pain that's myofascial, since about, we talked about this being the most common pelvic pain process. And in fact, there's some truth to that. That when looked at women with endometriosis, 77% had a myofascial component to their pain. So you can imagine if we just address endometriosis, we haven't addressed this part of their pain. And during that palpation of the pelvic floor, most women said that was where their pain was. We know that when with endometriosis, 60% of them almost have abdominal pain. And so that abdominal pain, as you know, can be quite visceral, could be bowel related, and 30% of women have sacroiliac joint pain. So what we see is that endometriosis is not a single diagnosis for most women when it comes to their pain presentations. There's a lot of other things going on. But what's interesting as well is I do not think that we should negate the impact of dysmenorrhea, so pain with your periods, because there are population-based studies, as this review shows that women with dysmenorrhea have a 2.5 odds of having chronic pain as well. And this includes pelvic and non-pelvic pain, so not just pelvic pain. And that dysmenorrhea begins in adolescence after puberty. And so does that give us a window of opportunity of really changing that needle in chronic pain by trying to stop the sensitization that happens as dysmenorrhea is initiated? And I think that's a very, very interesting conversation to have. But the role of cyclical pain and hormones goes much beyond the pelvic region. Here's a review that shows musculoskeletal pain and osteoarthritis are influenced by hormones. And another one down below, sensory neurons, neuroimmunity, pain modulation is affected by hormones. So all of pain almost essentially has some kind of hormonal component or pain that is modulated by hormones. And we know that in other pain conditions. We know when we talk about menstrual migraines, fibromyalgia, irritable bowel, all of these will shift with the menstrual cycle of women. And so again, showing how these areas of pain go much beyond the pelvic region as well. So I hope that you've appreciated how all of chronic pain is actually intertwined in pelvic pain in some way. How we need to go beyond pelvic pain as an anatomic area, and we need to go beyond its borders if we actually want to provide good treatment. And now let's look a little bit more about untangling it. How do we start this process? As I've shown you, how everything is fitted together. Now, how can we help to try and bring this into something that's more tangible? I want to shift again a little bit, maybe to the tree trunk, and to look at this again about how some of our biases, how some of our thought processes have maybe made it so that essentially we've almost avoided treating pelvic pain with some of what we've done. And trauma to me is a double-edged sword, because I've seen it where it's completely ignored and we don't even address it, even though it's important. And I've seen the other side of the spectrum where people and even learners that I see even to this day have said, oh, she has a history of sexual abuse, that's why she has pain. And I don't think pain is that easy to say it's one or the other, and there's not somewhere in between where the truth lies. But the other thing we don't talk about is the idea of shame and how that impacts how women present with pain, how they respond to what's going on, and how we can address it. So trauma is complicated. And I want to just show a little bit both sides of the story, because I don't want to dismiss it. I think it's incredibly important, needs to be addressed, but we also shouldn't just look at it from a pelvic pain perspective. We need to look at it again from the bigger trauma picture. We know that pain is more prevalent in women with a history of abuse, mental illness, and social stressors. However, on the other side of things is that it's more complicated than that. And that it's not just about abuse, but about the interpretation of that abuse. And when we start to break that down, the story becomes more complicated. But when we look at simply a history, because it's easier for us to do that, when we look at pelvic pain, definitely there's an association with childhood abuse, with sexual abuse, with verbal and emotional abuse, but we don't see that only in pelvic pain. We need to recognize that we see it in many other chronic pain conditions. And in fact, we even see it in arthritis. We think that arthritis is an inflammatory process, and we bring it down to a very nociceptive way of looking at it. And yet, the adjusted risk ratio of developing arthritis and of presenting with pain is higher in people who have a history of childhood physical abuse and childhood sexual abuse. And this is to just show how we can't make blanket statements. This is all part of that biopsychosocial model that we cannot negate. And so we need to identify histories and we need to address them in treatment plan, but we also need to understand the person's meeting, their context, and their perspective when we address it. And we should not just say, oh, it's because of this, or oh, it's because of that. There's so much more going on in the picture when it comes to pelvic pain. And shame is something we don't talk about. And shame is really shrouded in cultural norms. So now when I've been showing you the tree and the roots, now we're talking more about society, more like a forest, and how that forest is talking to these roots as well and impacting the experience of pain and where that comes from. And this shame often leads to either a sense of not belonging, being deficient, or not enough. And there's very little in the medical literature, but certainly we keep seeing it over and over again. We see it after childbirth, a woman presenting with pelvic pain and she's suffering from the pain, and yet she's receiving the messages from society, from her family, from her support, that she should be happy about this birth, that this should be a beautiful process, and yet this is not her experience. We see this in sexual intimacy, and we talked a little bit about it, about how society views sexuality, how women should be having these mind-blowing orgasms, and yet a woman has pelvic pain. And that's the mixed messaging she gets. In many societies, menstruation is still considered to be unclean. And one of my, can I say, pet peeves is that we use the word hysterectomy. When we take out a uterus, we use the word hysterectomy with its root in hysteria, that when women were hysterical, if we took out their uterus, it would treat that. What is that saying? Even that subtle language that we keep using, how does it change our views of pelvic pain? And here is a cartoon I took just off of the internet, and there are many, many other examples about what the menstrual cycle is, how women are to behave, and this is the messaging we're giving, and how does that impact how we present, how women either present or don't present with pain, is important to think about. And so it's very important when we see women, when we talk to women, that we do use a trauma-informed approach. Now, I want to separate the care versus talking about trauma. What we're talking about here is empowering women to be, to let us know what's going on, how we can make them more comfortable. And one of here is, and I've highlighted, is giving the woman the option to stop an examination at any point. And I'll have to be honest, I thought I was sensitive when I first started treating pelvic pain, and I recognized my own biases. I had the expectation that when a woman came to see me, because I was a gynecologist, it was understood she would have a pelvic exam. And I didn't really question that. And what I've noticed is, as I've shifted now, when I give women that power, there are many women with pelvic pain who will say, "Thank you for asking. I really don't want a pelvic examination today." And I can respect that decision. And that is important. There are certain messaging we do when we do a pelvic examination that I just want to highlight. Please never tell a woman to relax. Please never tell a woman just to spread your legs. I think we always need to be looking for verbal and nonverbal cues, and always returning. She has a permission to tell me at any time to stop the examination, and I will respect that decision. And this is really important, especially when it comes for examinations. We need to give that power back to women. So having talked about these things, we still haven't talked about how we can disentangle pelvic pain. And what does that mean? What I've done is kind of given you this kind of complex view of pain. I have focused more on the nociceptive part, but I really don't want to dismiss the whole biopsychosocial model of pain. And I tend to think of that model a lot like a tree, where we have the nociceptive inputs from the roots converging into the tree trunk, and then coming to the canopy or the brain, and that canopy also getting information from that psychosocial, from the society, that will bring that interpretation of pain. And I do not want to dismiss that, but recognizing that I'm going to focus a little bit about those nociceptive inputs. And where do we start? The first thing is you need to listen. You need to recognize your own biases and how those biases are going to impact what women are going to share with you. There is a reluctance for women to bring this up. And so you need to be open to the idea and pick up those nuances. Below is a study we've just reported that came from women entering our chronic pain program in Calgary in the pelvic stream. And we asked them, what do you think your pain is originating from? 74% said they thought it was gynecological. 26% thought it was musculoskeletal. Now remember, those numbers are almost turned. Most pain is musculoskeletal. But I think what's most important here is that 31% responded, I don't know. So they were presenting on average 10 years in their pain journey, and they still did not understand their pelvic pain. And so this is important when we start those conversations. The next thing is then to ask, what will trigger you even without treating pelvic pain, that there may be a pelvic component? Let's break this down a little bit. Women who present low back pain, lumbopelvic instability, that load transfer, and they're not responding to your, let's say, traditional management, and yet they seem to be compliant. Think of pelvic pain. If when you ask them about bowel function, they either have a history of irritable bowel syndrome, they talk about bearing down to evacuate, they may have a history of hemorrhoids. That should trigger something. In a similar fashion, if you ask about bladder symptoms, women with recurrent urinary tract infections or symptoms of recurrent urinary tract infections with a sterile urine should trigger that. Women presenting with frequency and urgency or straining and feeling like they do not empty their bladder well should trigger you to think there may be some pelvic process going on. Of course, if they come presenting with pain, and especially pain with anything inserted in the vagina or in the rectum. So I don't really want to sound crude, but you can think of it as penis, toys, fingers, tampons, anything that would give them pain, either on insertion. Idea of pain in the vulvar area, especially with sitting, and especially if they're riding a bicycle, they might tell you they stopped. And of course, dysmenorrhea, menstrual pain is important to think about pelvic pain. So all of these things can give you that indication, hey, there may be something going on. And where do we go with the approach to nociceptive pain, even without an examination? And certainly there's so much to talk about, but think about the fact that about 90% are going to have some myofascial, some musculoskeletal dysfunction going on. And I think of it a little bit like a graded approach. So begin with diaphragmatic breathing, and you'd be surprised how often there is a problem with just breathing. And I'll start with that. Start with pelvic stretches, and these end up being mainly pelvic stretches, looking at even hip mobility stretches from there. And then I begin usually an exercise or what I would call a movement program. And the degree of movement depends on the amount of dysfunction. And so I've just kind of graded some of the ideas where I'll start women. Certainly that goes with a discussion and sort of what they would like to do. But these are things that I sometimes will suggest. And in there as well, of course, is aquacise, which is terrific for pelvic pain. And then the other part is to already begin that hormonal suppression. We did show how pain fluctuates, how you get these peaks and valleys of pain throughout the menstrual cycle, and we can bring that already to a level and bring it to a lower level that's more consistent, and already that has a huge impact. And there's really two first-line treatments. The first one is combined hormonal contraceptives, and the key here is to do it continuous. So we want to essentially knock out periods, and we can do that with hormonal contraception. Do we know it's safe? And the other way we can do it is with progestins. And so overall, we want to think from a nociceptive approach that you have somatic, you have visceral. We want to be addressing the both of them because they talk to each other. And we want to be addressing pain as well. I could spend hours talking to you about pelvic pain, about specific areas of pelvic pain, about the physical examination, and unfortunately time constraints won't allow me. But I hope that overall what you've can appreciate is that
About 2 minutes left.
person who presents with pain, the first thing is to recognize that almost all of chronic pain is somehow intertwined or linked with pelvic pain. Quite interesting, isn't it? That to try and help people who are presenting with this, understanding that complexity allows us to start to untangle this and to address it in a multimodal approach to this. That I've showed you a bit of a simplified treatment plan. What questions to ask to already trigger that something may be going on in the pelvic region, and some of the even easy things that can be started as you go on with further evaluation of the pain to bring that in. I've not talked a lot about the biosocial, except in the context of what it means to society to be looking through a gender lens and to recognize our own biases, because the other areas of that psychosocial, I think, are also topics within themselves that are that need to be addressed in almost a broader and a more longer fashion than we have today. So with that, I'd like to thank you. I hope this is just the foundations for having more conversations about pelvic pain and starting to bring that to the forefront of chronic pain management. Thank you very much for your attention. And do you have any questions?
Okay, so just a reminder, go up to the microphone if you have a question. And thank you for tuning in live. I know, what are you doing there? Tell us.
I did take a picture of this background. That's not actually where I am right now. It is raining and it's night here in Paris. But I do want to share something pretty exciting, if I can do that before we ask questions. When it relates to pelvic pain, is that yesterday I had the opportunity of actually having a meeting with the WHO representatives to try and bring pelvic pain to the forefront of their agenda, and they were incredibly receptive. So this is something I'm going to continue pursuing. So I'm very excited about actually having had that opportunity.
Yeah, congratulations. That's very good news. We're all clapping. I don't know if you can hear that. Okay, I thought I saw a few people dashing toward the microphone.
Thank you for the, perfect talk. I just was wondering if you can give us some information about irritable bladder syndrome.
Sure. I actually have a whole talk on that, if you like.
Next year.
The word now that we're using for it was interstitial cystitis, or now we use the word painful bladder syndrome, and there's actually a lot of very interesting new information that's coming out on it. The easy answer to that is you want to think of painful bladder syndrome as a neuroinflammatory disorder, and so women are often presenting it, and men as well, with what appears to be recurrent urinary tract infections, and yet when you do urine cultures, they come back negative. And so that should be your first tweak, that there's something else maybe that's going on. I don't know how much you want me to talk about it. I'm more, as I can say, I can talk about it probably all night here. But one of the places that I would maybe send you if you wanted more information, and hopefully maybe I can talk about it next year, is it's called the IC network. And it's got a lot of information. So I'll often send women to that website. It's very good. I hope that helped.
Any other questions? Yeah, did you want to keep talking about
Oh,
interstitial
yeah,
or
let-
anything else? I mean, I think people are a bit shy. Speaking of quiet and shame and stigma, they're afraid to come to the microphone and ask a question about this subject.
my gosh, you know what I think is maybe everybody's contemplating that they should have become a gynecologist.
Ah, yes, I do think that's part of it.
So listen, let me keep talking about painful bladder if you like. So we see young women, and it's not uncommon for women to have bladder infections. So I don't think it's unreasonable the first time a woman comes in, usually with burning, right, dysuria, frequency, urgency, likely nocturia, getting up at night to pee. And she comes in your office, you're kind of busy, you write an antibiotic order, and she feels better. And she goes home and she thinks you're wonderful. But then next thing you know, she's back. And what you're noticing is she's back more and more frequently. And the interval of time she's coming back is maybe getting shorter. And with that, if you were to ask her, there's a good chance she's also, if she's having penetrative intercourse, that she's also having pain with sexual activity. So the first thing I think in a woman who returns back with bladder infections is you need to send off a urine culture. That would be the first step. Is it truly, because if it is recurrent urinary tract infections, you're going to go down a completely different pathway of care than if it doesn't come back. Now, some people, what's interesting is that antibiotics always make women feel better when they have painful bladder syndrome. But what you're finding is that is not consistent, and the interval is getting shorter and shorter. So the way to treat painful bladder syndrome first is to acknowledge it. The second is to recognize as well, there is, like all of pelvic pain, often a myofascial component to her pain. So it would be very reasonable to initiate as well physiotherapy if I have access to it, or I certainly initiate some kind of, let's say, movement strategy for her. For the bladder itself, the first thing I do is I increase fluid intake, and I look for bladder irritants. The most common irritants are alcohol, anything with caffeine and its decaffeinated counterparts. I have a lot of women as well who will identify spicy foods or very acidic foods. And other women will find there are certain things that they are more sensitive to. Oxalates was a big thing at one point. It can still be for some women. But I first start them to say, especially if they're having days that are good and days that are poor, is to start to look at their dietary intakes and if they can identify anything. So I'll always start conservative. After this, it depends on how much discomfort she's having. Second line treatment, often when you look at the guidelines, go to antimuscarinic agents or beta-3 adrenergic receptors. And those are medications that we use for overactive bladder. So the common ones would be tolterodine, soliferin, and I can't even pronounce today, sorry, and mirabegron. But I find I don't use those normally as second line because I think of them as symptom management more than active management. And so I will go to more neuromodulatory medications. And the one that I often go to is amitriptyline or potentially nortriptyline short-acting. And the reason I do that for bladder is a number of reasons. The first one is we know that these medications can often work for neuropathic pain. Number two, if you look at the side effects, one of them is urinary retention. And so when a woman has frequency, then having decrease in frequency always helps a lot. And the other things that a lot of women have troubles with is nocturia. So they're getting up every half an hour at night. Imagine what that's going to feel like after even just a week. And so because amitriptyline is sedating, it often can help with sleep. So I'll start it at night and then increase the dose from there. If there's too many side effects, especially in the morning, then I'll go to a shorter acting one like nortriptyline. And this is where I'll start. Of course, I would look at all other aspects of her pain profile. So this is where myofascial, very common. And as I had said, things like irritable bowel, menstrual disorders are very common as well. So this is where I usually will start. And I think the other part here is to really talk about the education of what it is and what it means. What's interesting with painful bladder syndrome is we don't know the long-term fluctuations that happen. So there are actually women who do get better over time, as there are women whose symptoms will worsen. I'll only resort to cystoscopy if I'm finding that this initial management is not working, and I want to make sure. So this is sort of like where I start in that dialogue, and that's kind of a simplistic view, and it's a bit of a medical approach, isn't it? But I wanted to focus more on that because I think if we start talking a lot the psychosocial, then we move away from painful bladder, we get into the pain, and I'm assuming that I have a very educated audience here, and you know that this definitely plays a role.
Dr. Becker.
Hi, Magali. Yes, you can talk forever on bladder, can't you? You mentioned neuroinflammatory issues in the bladder and so forth. And this whole thing is starting to sound an awful lot like migraine. Can you say a few words about whether the pelvis and the head have something in common that makes them these unique parts of the body that are there similar mechanisms involved? Is CGRP a big thing in interstitial cystitis?
I love you bringing this up, and I know we've had these conversations, and I think the conversation I've always said, of course, was that pelvic pain is really the source of everything. And I think you're absolutely right. Nobody has looked at CRGP for pelvic pain. I thought it would be very interesting, but trying to try this off-label, as you know, is almost impossible. I think when we're getting into a lot of these mechanisms, I do think the neuroinflammatory process is incredibly important. And I think that's one of the things we're seeing, especially in women who have pain and endometriosis and this whole visceral pain cycle. I'm really going to be very careful because when we use the word neuroinflammatory, I love it because it means everything, right? It kind of covers everything about pain. And so we have to be careful how we do it. But some of the things that are coming out that's very interesting, I think in pelvic pain, is, and it will go into mainly into the inflammatory part, and I think we're going to see more information moving forward, is the role of the gut microbiome in this process. So there's a lot of theories, especially when it comes to painful bladder, but we're seeing as well with endometriosis, is that maybe painful bladder, when we treat with antibiotics and women feel better, we haven't treated the bladder for a bladder infection. We've actually decreased the gut biome levels down. So we're seeing less inflammatory cytokines. And so we're seeing a decrease in pain. And so I think this is super exciting because it opens up avenues for care. And there's actually emerging evidence that, you know, endometriosis can be modulated sometimes by dietary changes as well. So I would agree with you that I do think there is a certain commonality in chronic pain, and pelvic pain is not special that way. And that we should really start, and this is why I think this talk is so important, is to recognize that, you know, pelvic pain, it's always been about gynecology, that we need to broaden our view of pain if we want to bring some of these treatments to women. So absolutely agree with you. Gosh, I can talk about a lot of things, can't I?
Yes, but we appreciate your expertise. One last quick question, and then I'll introduce Dr. Atul Galar.
Thank you. Now after all this talk about broadening our view, I actually have a very specific question. If you have any pearls for management of vulvodynia and postmenopausal women, particularly those older women that present with burning pain in the vulva, that's very, very bothersome.
Yes, of course. vulvar pain is very dear to my heart, and we actually used to have a vulvar program at the Chronic Pain Center, and it's something I would love to get going again. So vulvar pain as well, I do believe, is neuroinflammatory. We tend to put it into the banner of chronic pain. So when I see women who present who are menopausal, certainly my first line of treatment is always vaginal estrogen to begin with, because we want to take out the genitourinary syndrome of the menopause to begin with. We want to take that layer off, and for some women that's sufficient. So I'll start there. The second line treatment, and again with vulvodynia, what we're finding is there's a lot of myofascial component, but I think where we've probably misstepped a little bit, if I can say that, is we've really focused on the pelvic floor when we should be focusing on the more superficial muscles in the pelvic floor, such as the transverse perineum, the bulbar cavernosus, and the ischial cavernosus. And so we need to be spending more time there. So the next step I'll do, if that's insufficient for women, is I'll usually start with more of a focused area. So women with vulvodynia don't tend to like to take oral medications. So I will usually go with ointments and compound from there. The place I start is often with lidocaine because that's the best evidence. And then I'll go to compounding medications such as amitriptyline 2% and gabapentin 6%. Now, I think there's something I'd like to say, though, if you're going to do that, is now I trial all women on bases before I mix it, because I have some women who can't tolerate any of the bases. And so we need to find a base that they're not reactive to. That's sort of a simplified. Again, where I send women as well is to a website called NVA.org. That's for the National Vulvodynia Association. There's a lot of information there. More to come on vulvar pain. That is also a great 1 hour talk. So I'm glad you're bringing all these questions forward.
Well, as a longstanding member of the planning committee, I've noted these things and we'll have you booked for the next few years. Thank you very much, Magali. I really appreciate your knowledge and wisdom for the group and from tuning in from Paris. So please join me in thanking Magali for a wonderful presentation.
Thank you so much.